Hello, everyone. It's Dr. Durst, and welcome to the channel. I am a traditionally trained physician that specializes in regenerative medicine with a focus on sexual medicine. And today I want to talk about testosterone metabolism. This is an exciting format because I'm going to put some slides up so you'll have some visuals to go along with me talking to you about it. And these are conversations we have on a daily basis and a weekly basis with patients, and we deep dive into the numbers and the reasons behind adjustments and optimization that we're doing. And so this is going to be a frequent resource for our patients too when they want to refer back to something we talked about. So this will have some slides with it, and testosterone metabolism is what we're talking about today. So what is testosterone? That is a sex hormone in the body, and it is a life force for both men and women. So when you just don't feel like yourself anymore, you've lost that competitive edge, things feel different, they feel different, and patients are seeking solutions, and they're approaching their doctors, their urologists, their primary care doctors, their gynecologists, and what's happening is those conversations end and they don't get solutions, and they, for women, are just ignored. So women have been left behind with this. And so we're going to talk about testosterone. It is the most abundant circulating hormone in a woman's body as well. That is a misperception and people don't understand it. So we will talk about this as it relates to men and women today. So what are the things that it helps with? Lots of things with both men and women for symptom control. Men, testosterone is the primary sex hormone, and so it does result in sex characteristics for men as they are developing. But so what does it do to improve symptoms? So it can cause brain fog. So if your testosterone lowers, you might have some brain fog, low energy, libido might drop. You might have decreased muscle building and not have as much strength or recovery. You might gain some weight because as you lose muscle, your muscle metabolizes faster. So you might have some weight gain and body composition changes. But a couple things people don't think about is mood and sleep. And so if you're not sleeping well, you're moody, you don't feel well, it could be a hormone imbalance, and it could be testosterone. Yes, better erections plays a role, but that is not on the top of the list because that is not the primary reason why we see men and women for hormone optimization on a daily basis. So there's lots of behind the scenes things that testosterone does as well. So if you simply think of it, it's bone, brain, and heart. And so as we age, our hormones decline and inflammation in the body increases. So you have bone or brain disorders. So inflammation in the brain is Alzheimer's and dementia, memory issues, cognition gets slower. Bone, you can have bone loss when testosterone decreases, cardiovascular risk factors, insulin resistance, and abnormal lipid panels. And in fact, you have an increased all-cause mortality when you have a lower testosterone. And there is lots of data to support that. So testosterone measurements, nanograms per deciliter. For men, it's a wide range, 300 to 1,000, and those are all age ranges. So that's a large range. So if you were 900 and now you're 300 and your primary care physician tells you you're normal, maybe it's not normal for you, and that's why you're feeling different. So you could be in that range, but you could be a third of what you were before, and that matters because you're feeling symptoms. And hypogonadism is low production of testosterone with symptoms, and that can happen with men and women, and gonads are ovaries and testicles, and testosterone is produced in the ovaries primarily, and the adrenals with women, and testicles for men. And so women, there is a range, 15 to 70 is a more random range. There isn't a solid range. There isn't an acceptable way to treat women. It is very vague. The guidelines are vague. It's just for low sex drive, hypoactive sexual desire disorder. It's male products, so again, 15 to 70 is a random range. So if they tell you you're within a normal range, is that normal for you? Do we know what normal is? And so we are frequently shooting to a pharmacologic level, and there is no one specific level that tells you what gets a patient feeling better. It is individualized and it depends on the patient. So So hypogonadism or low testosterone production can happen with age. It can happen with weight. There is fat cells, and they have 5-alpha reductase, which can convert that to estrogen, and I'll show you a slide on that. And so weight and losing weight helps improve your testosterone. There's lots of things you can do that naturally improve your testosterone, not just the hormones that we can optimize, but you can also boost your testosterone in multiple ways. And there's things you can do. And being active and limiting toxic exposure. So everything on there, like weight loss, getting more fit, getting more active, and controlling plastics, exposure to endocrine disrupting. And there's another video that we have on that. So just stay away from plastics, heating plastics up, drink out of glass, simple little things that you can do to boost your testosterone. So here's the sex hormone pathway. So cholesterol goes to pregnenolone, goes to DHA, and then there is cortisol, and there is a sex hormone pathway. So if you're extremely stressed, it's a high level of stress, it's prolonged stress, excessive, then you'll have a diversion of your sex hormones to a cortisol pathway, and that you don't want. So breathing techniques, meditation, anything that can control your stress. And again, if your mood is not good, you're not sleeping well, your stress level can go up. And so test can help with that as well. So just things to think about. And then test down here can convert to estrogen and DHT, and we'll talk about that. So your metabolism of testosterone is primarily to DHT or dihydrotestosterone, and that's done by an enzyme called 5-alpha reductase. And then you have aromatase, which converts testosterone to estradiol. I always say that you want to keep testosterone if you are making it, or you want to keep testosterone if you're giving it. But there are conversions, and those naturally happen in the body. And so just knowing those data points and checking levels is important. And DHT and the 5-alpha reductase enzyme, there's at type 1 and 2, if we really wanted to get into detail. And type 2 is more specific to the prostate and the hair follicle. And so those involve side effects. Aromatase is the enzyme that converts it to estrogen, E2 or estradiol. So we want to look at all these data points. Total testosterone, there is a sex hormone binding globulin, which is a protein made by the liver that binds testosterone. So 60 to 70% of the testosterone that's in the bloodstream is bound by that protein and not free to act. And then there's free testosterone that is free to be active. And then there's a mild proportion of that is also bound to albumin. But estrogen, we want to look at that. We want to know what that ratio and conversion looks like for a patient. DHT or the dihydrotestosterone, we want to know what that looks like for a patient. And if you have side effects, we want a baseline to compare it to. LH and FSH are hormones released. So you have gonadotropin releasing hormone that is released by the hypothalamus, goes to the pituitary, releases LH and FSH, which then act on the gonads to stimulate sex hormone production. So those are things you want to look at, especially if a man wants to maintain fertility. And then prolactin. So if you have a guy that's really young or an excessively low testosterone level, then you want to look at prolactin. And again, I agree with a lot of what I see on social media or podcast about low T clinics being a one size fits all, and that is frequently the case. And we see those patients come to our clinic for better management, and they get that because hormone optimization needs to be well thought out, well practiced, and customized for the patient. So it needs to be done right. You need all the data points. As we age, those decline. If you're feeling symptoms and you need optimization, there's things that you can do to optimize your hormone production in the body. But then if it needs to be optimized with hormones after that, you want to go to somebody that specializes in hormone optimization. So the sex hormone binding globulin. So that is basically a protein made in the liver. It will bind and kind of keep a relatively stable portion of testosterone free and active despite different things that are going on in the environment and in your body. And so that's the whole point of it. It does increase with age, which means if the binding protein increases with age, that your testosterone will go down. Estrogen increases at thyroid or hyperthyroidism increases at liver disease. insulin can decrease it, but insulin isn't something that we want to see increased in the body. And then there's lots of supplements, and that's a separate video on just supplements that can decrease the binding, because sometimes men will have a normal testosterone total, but abnormal free, and free testosterone should actually be about 2% of the total. And so that's what you're looking for. This is just the free, and the albumin is like loosely bound, but this is not active to work. So when we're talking about test optimization, the ways that we can give it, so we get all the data points, we sit down with a woman or a man, we're talking to them about their symptoms and what is happening with them right now that's putting them in front of us, that we're having a conversation. What has changed in their life or with their primary care doctor that is making them seek solutions and making them explore hormones as an option for that. So we want to deep dive into the symptoms they're having, because that's how we customize it for them. But then we want to talk the numbers. So we get blood work, we get all those data points, and then we sit back down and we do a planning consult. And then we do that every 3 months. We're following up, getting blood work, and sitting back down and talking numbers and ratios and what's happening and how are their symptoms. And sometimes it's easy to get somebody pretty stabilized, but then there'll be something happen. So those frequent conversations, you get to know your patients well. We get to know our patients very well, and they get to know us well. It might not always be a good thing, but it's necessary. And so there's lots of different things that we can talk about on how. And I feel pretty strongly about some of them. Routes of optimization for testosterone, which is what we're talking about now, could be there are no oral testosterone treatments right now. It was bad on the liver, so there are no FDA-approved products on the market for oral. You can have compounded troches that go underneath the tongue. I'm not a fan of those because of I am in some things, but not in testosterone, because it shoots that level up. And so you get high peaks and then you get lows, and you don't get a steady state of testosterone. So you don't feel very good. That can almost be like a pre-workout or a pre-sex. That's not how we use it. Topical does the same thing. It doesn't absorb well through the skin. And so you get fluctuations and highs and lows, and that gets you more side effects. And so there is also 5-alpha reductase, which converts it to DHT, which is the stronger metabolite of testosterone. So it's 10 times stronger than testosterone. It binds to the androgen receptor more, and it causes all the side effects. And we'll talk about the side effects. So, and that 5-alpha reductase is in the hair follicle. And so if you do it topically, not only are you going to get fluctuations, but you're also going to get more conversion to DHT, which causes side effects. So I'm not a fan of any troches for testosterone or topicals because of the fluctuations and the increased risk of side effects. And then injections, if you're bypassing the 5-alpha reductase in the hair follicle going underneath the skin, injections are possible. And again, dosing of that, like at least a twice weekly dosing for injections, will get you less in the way of side effects. You can do a microdosing in a daily if you really wanted to come closer to that steady state release of pellets. And also there's smaller injections, even though it still is an oil, it's a smaller injection amount and potentially a smaller needle if you're doing it at microdosing on a daily basis. But that's a lot of detail. We talk to our patients about that kind of detail, and we are having those conversations. The providers at Revitalize are having those conversations in depth with patients every day. And it's needed. They need to understand what's going on with their body and what we're doing with their hormones. And if they have any questions, there isn't a question when it comes to hormones for men or women that we haven't heard. So we encourage them to reach out with us or reach out to us for anything, because that is how we can optimize. If we know if they're having symptoms or issues that we can adjust, most of that can be based on a conversation alone, because frequently we don't need to do blood tests to see where we are, because just based on the conversation, we can usually tell what needs to be adjusted. But if we ever are in doubt, still questioning, need to do spot tests, we can, or even just convince a patient because they get pretty fixated on what might be happening, even though that's all not always based on this physiology. So pellets is by and away the best way to get women in men feeling better because you get a steady state. It's a small procedure in the office. We've been doing them for 5 years now and no issues. No significant issues, I should say. So men get more pellets, so they tend to get a little more in the way of tenderness. And if you're going to have issues, usually it's with a man. But we use cholesterol pellets now, which just are a binder for the hormone. So it incorporates very well into the fat. And so it's very rare for us to find a man that has a reaction to the pellets now. And by the way, the best way to get women feeling better, because it's a small incision, they don't get very many pellets, and then you get a steady state, less fluctuations, less in the way of side effects. So again, if you're going to get side effects, we'll talk about what those are. DHT, when you get a conversion to DHT, it's the stronger of the androgen, 10 times stronger than testosterone. So is the one that tends to cause side effects. It doesn't matter what route you have. You're still going to get the same side effects. But again, if you have more in the way of fluctuations, like we talked, you'll have more in the way of side effects, but they're still the same side effects. So hair and acne, hair growth doesn't tend to be an issue with men, but hair loss or thinning is an issue with either sex, and it's not acceptable. But there are so many ways to minimize side effects or prevent. And again, just not getting those fluctuant levels or going too high is the primary key. And then acne, and there's ways to treat DHT and prevent side effects just with the spironolactone, which inhibits, the androgenic receptor effects of DHT. But prostate can have symptoms with men because, again, there's that 5-alpha reductase in the prostate. And so you can get enlargement, urinary symptoms, lower urinary tract symptoms, urinary frequency, you're up at night, you can't empty your bladder, you feel the urge to go. Those are potential prostate symptoms. And so those are the ones that we would want to get a little more aggressive with treating because that conversion is causing an issue. Estrogen, when you get a conversion, it's very rare that we have to block the aromatase enzyme. But again, swelling, emotions, you're crying because the other team scored a football, or you're crying at, things that you normally wouldn't, or you're getting emotional or worked up. Vaginal bleeding in women, if they still have a uterus, is a side effect of estrogen. It's very rare that you're going to get enough conversion in a woman to estrogen to cause those levels to go way up, because remember, we're already making it, or we're giving it if they're menopausal usually, and there's exceptions, obviously. This is kind of a blanket presentation with that. And so it's very rare for us to see that estrogen spike to the point of side effects just with testosterone. But breast tenderness and can be an issue with men. So most of the estrogen effects are something that we're seeing with men when it relates to a testosterone side effect. Usually estrogen side effects are because we are optimizing estrogen in a menopausal woman, but just so you know that the side effects are the same when it comes from estrogen. So enzyme blockers such as 5-alpha reductase aren't used often, and only if they have prostate symptoms. Otherwise, it can cause erectile issues, and some are reported to be irreversible, so you don't want that. Aromatase inhibitors very rarely used as well. And so just to go back to that aromatase, the anastrozole can prevent that aromatase conversion to estrogen. Doesn't need to be used that often, but if you're having severe breast tenderness, any enlargement, man boobs are harder to treat after they develop, so we would want to know. And then sometimes a very low dose would be necessary, and sometimes it's an acclimated side effect, and so it's not used for very long. So again, how do you find a provider for you? And so you want to find somebody that's going to work with you on your journey to feeling your best at all ages. And so it's hard, but sometimes we get a lot of people that reach out just on social media, looking and on the YouTube videos, looking for providers in their area. And so A4M is a great resource to look for somebody that is a specialist in hormone optimization or a hormone specialist, because again, they know the endocrine and the hormone system better than most primary care doctors. And a lot of primary care urologists and gynecologists, and those are like, again, it's a blanket statement, there's exceptions, but most of the time we're seeing patients because they haven't gotten the solutions in the traditional system. And insurance-based models don't often work because insurance companies dictate the care that you get. And so they tell you how often and how long you can see and what kind of tests you can do. And with hormones, that just hasn't worked very well. And it is hard to optimize and to customize when an insurance company is dictating the care. And so A4M is a good source. You can find providers there. Look for reviews, but remember, you're interviewing your physician. Even primary care physicians, like your physicians across the board, are working for you. And they should be working for you. And again, the insurance company isn't the one that is actually providing the care, it's the physician. So just make sure that when you're looking at physicians and specialists that you are looking and interviewing so that you know it's a right fit for you. It's got to be a right fit both ways. So if you have any questions, experiences, please leave them. If this video was helpful, please subscribe, share it with friends. And if you want to hear about anything else, please let me know, because I'm willing to deep dive into anything wellness or sexual wellness. And thank you.